on YouTube. I'll video you right here.
I would prefer not to be on YouTube for people to make fun of, but I just really want this awesome presentation to be there. Alright, so this is the highly anticipated sequel to Monoclonal Antibodies Part 1. It's titled Monoclonal Antibodies Part 2.
I was actually officially excused from Pharmacy Practice Committee because this was such an awesome presentation.
Oh, were you? I emailed them too.
How do I get this to go away?
Minimize next to the X.
Is that what this button means?
Oh, arrows.
Okay. Alright. And I have to give a shout out to my awesome co-resident Lauren for adding the artwork to this presentation.
Oh yeah, I hacked into her presentation on J Drive.
It's actually true. So, alright. So I kind of broke it down. These are the objectives for the presentation overall.
Where's the music?
There was Elsa from
Okay.
It's a good song. I love it.
So we're first going to review the different monoclonal antibodies that are used to target solid tumors. So the part 1, for the, if anybody wants the slides, they're on the J Drive, but those were ones that targeted more of our hematologic conditions. And then we're in each of these, we're going to kind of dive into the mechanisms of action, what they're used for, what to expect as far as adverse effects, and then identify a couple of pertinent clinical trials too along the way, so we can kind of determine where these are being studied more recently. Alright, so, and I broke these down by kind of the receptors they target. So this is our first one, HER2. We're going to start with trastuzumab or Herceptin, which we see quite frequently. So I started off with the mechanisms of action for each of these. So this one binds to the extracellular domain of the HER2. And through this, it mediates antibody-dependent cellular cytotoxicity, which then inhibits proliferation of the cells which are really overexpressing the HER2. And because I know from the 2 people who attended part 1 that the videos were so popular, I thought that I would include one here if I can get it to work.
They had no sound though. I actually had sound.
Are they
in
languages
English
again?
Yeah, are they in English this time?
Yeah, oh no, the sound. Is anybody?
You probably got it.
This is in English this time, it's true.
No, it's not worse.
You don't have it on mute on the screen, do you?
No, I don't.
Not there.
There's something that you have to do on the side of it that Jenny does.
On the side of the TV?
Yeah.
Like turn the volume on?
Yeah, maybe. Because I had this in my social media back when I used to do the
We're really smart.
other side. Other side.
Sorry to all those people who are watching this.
Is there a
later.
remote with the TV?
Please do not touch.
Right.
This never happened.
Oh wow.
Yeah, there you go.
I found it loud to do that.
Okay.
Okay.
Okay, so let's start this over. This is a pretty good video and it actually has a couple of different drugs, so we'll pause along the way. That we still can't hear. Oh no. Nope. Alright, maybe it's so it'll kind of depict it as it goes along too, but you can see the different HER2 kind of receptors there and the domains that it'll target.
I did not know it was red.
That HER2 was red.
I didn't know.
Just for you, Mike. Just for you. So even though you cannot hear the excellent narration, I would highly recommend going back and watching this video. It's very informative. But it'll show you where trastuzumab comes in here in a second. Well, it's not snowing, I don't think. Here is trastuzumab. Is it Jenny's? Oh no.
Still shows up back here. Sorry.
I think my favorite part about this is that it's being recorded.
Yeah, so people on the policies.
Even better.
Maybe just like movies.
we can do
I
that.
don't know what I did now. I was just touching the bottom. Sorry.
Alright, so, well, we'll just go ahead to
First of all, I don't want you to get home and
Oh.
suddenly
the
make
next
your
slide
family's
here.
instructions again this thing.
It's one of the HDMI's, Mary.
Great. The second I'm counting on.
Alright,
My first page up there.
Yeah.
so as far as indications for this drug, sorry you guys are gonna have to turn around now, the back one. So the FDA approved indications are at the top here. So you can see that breast cancer has a couple of indications depending on whether it's adjuvant treatment or for metastatic disease. And I tried to write what some of the common regimens are too, if it's used with other as part of a regimen with other agents. And then it's can also be used for gastric cancer that's HER2 positive, and that's with cisplatin either tape or 5-FU for 6 cycles. And some of the off-label indications are for early stage breast cancer.
I just did the button. I swear I did.
For early stage breast cancer, either locally advanced or
All I did
inflammatory
was push the
in
button.
the neoadjuvant setting.
The picture's back there, so I don't know.
And so the loading dose for this, the dosing schedules vary a little bit based on
It's just a presentation.
how frequently it's given
Sara's
and
doing it.
what other spread. I have a
She
video.
probably did.
But what other agents it was given with? So the loading dose is typically 4 to 8 mg/kg. That's infused over an hour and a half, and then subsequent doses. It looks like the FDA approved doses are either 2 mg/kg every 7 days or 6 mg/kg every 3 weeks. So, which they kind of equate. It just depends how frequently you're giving it. And then dose adjustments, there were no recommended dose adjustments for renal dysfunction, but they did say that when they did clinical trials that looked at the clearance of the drug, it does not appear to be based on serum creatinine, and they studied that up to 2. And then there were no specific recommendations for hepatic adjustments. A lot of these monoclonal antibodies, and I'll kind of detail them as I go through, will have dose adjustments for toxicities. About whether to hold the dose, slow the infusion, decrease the dose, or discontinue completely. So if cardiotoxicity occurs, this would manifest in a reduction in the left ventricular ejection fraction. So they recommend monitoring it at baseline and kind of throughout therapy. And then infusion reactions is the other big thing. You'll see this again and again with the monoclonal antibodies. And then they have specific recommendations based on the severity of the reaction. And they recommend if it's severe or life-threatening to discontinue completely and don't retry the drug. And for a lot of these, they have kind of specific administration instructions too, so I detailed these as well. This is kind of unique in that it says it shouldn't be administered with D5. So normal saline should be the base solution of choice. And then I just put the kind of time that you're giving these medications over. So the loading dose should be over 90 minutes. The maintenance dose is when they're those smaller ones, the 2 mg/kg can be over 30, or if they were tolerating the maintenance doses pretty well, to do it over 30. And that's another common thing you're going to see throughout the presentation. That the first dose, because of that risk for infusion-related reactions so high, is administered over a longer period of time. But once they've tolerated that, their risk of infusion reactions really go down. And so they can be given over a much shorter period of time, which patients I'm sure love as well. And now the famous black box. I put black box warnings for all of these, literally a black box. And then other adverse effects are listed below. So as I stated before, this one can be associated with some cardiomyopathy and reductions in the left ventricular ejection fraction. And so the incidence is highest in patients who are receiving this with an anthracycline-containing chemotherapy regimen, which makes sense. And then if they have any signs or symptoms or evidence of cardiomyopathy, it's recommended to discontinue the drug completely as well. For the infusion reactions, I kind of went through a little bit of that. It looks like a lot of it, 21 to 40% of that, is really chills and fever. So those are kind of the most common things you'll see. And then most of the infusion reactions that occurred within 24 hours of the first infusion. So again, if you can get past that first infusion, your risk really goes down.
So how often do they recommend checking like ejection fraction while people are getting trastuzumab?
So I didn't see any specific. Some of the black box warnings will actually say check it before or like every 3 months or in a baseline. This one didn't specify it. It just said periodically throughout therapy. But I would think that it's something I'd probably monitor every few months to make sure that, because a lot of these they said it can be either symptomatic or asymptomatic. So it's definitely something you'd want to monitor.
I'm just asking because I got requests for ejection fraction to be, or UTTE to be built within the treatment plans every 3 months from one South Park.
I didn't see, yeah.
But I hadn't.
No, some of the drugs specifically call this one out, and this one did not. Yeah. Pulmonary toxicity is another possibility with this one that I wasn't really aware of actually. So this can manifest itself as shortness of breath, hypoxia, interstitial nephritis, pulmonary infiltrates, pleural effusions, non-cardiogenic pulmonary edema, and then ARDS is the other thing that they have seen. Oh, perfect. So I guess I was surprised at the wide variety of different manifestations of pulmonary toxicity that was seen with this drug. So definitely something to educate patients about and to be aware of as people verifying those orders. They did say if a patient has kind of any sort of like ARDS or interstitial pneumonia or pneumonitis, to discontinue the drug completely because that's probably not something that they're gonna a rechallenge is gonna do. They're not gonna do any better with that. And the last black box warning is just the pregnancy risk. So they found that patients who receive this drug when they're pregnant, it could result in development delays in the lungs of the kids, and then skeletal manifestations as well. Bones. I'm really killing it today. So a lot of these monoclonal antibodies will have specific recommendations saying that women of childbearing potential should actually be on birth control, which is not something I was aware of at all. Not something I looked at. So something to be kind of thinking about going forward. And then some of the other adverse effects I listed here. So pain, almost 50% of patients experience pain with this medication, which I thought was pretty high. And then a lot of the things you'll see in a lot of these monoclonal antibodies, so things like skin rashes, GI symptoms, risks of infection, and overall weakness. All right, pertuzumab. I take it we did not get the video to work. No? No. Okay. Well, it'll be a really fun back to the video graphic here that we will not get to partake in. But again, it was a really helpful kind of video about these drugs, so if you're interested in learning more, it's a really good overview. I like to see things visually. I'm sure I'll give you a surprise. So the mechanism of action, this is another one that targets the extracellular HER2 domain, but it inhibits the dimerization domain, which is a different epitope on the HER2 receptor. This interferes with downstream signaling and basically causes the cells to stop growing and apoptose. I don't know if that's a verb, I might have just made that up. And then, like I said before, it binds to a different epitope than trastuzumab, so when they're used in conjunction, you get a more complete signaling when they're used together. So FDA approvals for this one, this is FDA approved for HER2 metastatic breast cancer. If they have not had any prior HER2 targeted therapy, or if it's metastatic disease, they use it with trastuzumab docetaxel. And it can also be used in the neoadjuvant setting for locally advanced or inflammatory or early HER2, and that's also with the trastuzumab and docetaxel. And I don't know why I did that twice. So the loading dose for this one, this is a standard dose, which is kind of unique in chemotherapy. But this is a loading dose of 840 milligrams with a maintenance dose of 420 every 21 days. This is another one that didn't have any specific recommendations for renal or hepatic toxicity, but for different toxicities, they had, stop or slow they had specific recommendations for infusion reactions. If they have serious hypersensitivity, again, completely stop the drug. And this is another one that has potential cardiotoxicity, so you want to make sure that the ejection fraction is being monitored. For the administration on this one, the first dose goes over a full hour, and then all subsequent doses, depending on how they tolerate that, can be given over 30 to 60 minutes. And then I always have questions about the order. I know that there's some sort of thing, but I tried to call those out too if they were specifically called out in the package inserts about what order to administer the drugs in. So if they are going to be administered, it said that you could do it in either order, but that obviously both should be administered prior to the docetaxel if they're being used to that regimen. And then it recommends administering patients for a half hour to an hour after each infusion. So the black box warnings for this are very similar to trastuzumab. So the cardiotoxicity, in this black box warning, they recommend to discontinue completely for any clinically significant decline in the ejection fraction, which can occur in 8 to 16% of patients. So that's not an insignificant amount. And then again, this is another one that has embryo-fetal mortality associated with the drug in pregnancy and also developmental issues for the palms. And this is one, that, again, that specifically calls out the risk for need for contraception in females. All right, so trastuzumab. So this is the one that I thought was coolest in the video because I love the ones that have like linkers to things. So another HER2 antibody, which has a drug conjugate. So the trastuzumab component is the part of this that targets the HER2 receptor. And then it has this DM1 microtubule inhibitor. So, and it's linked via this little thioether linker. So I'm going to do my best to detail this video. So basically the trastuzumab component targets the cells. It gets brought in into the cell, and then once it's in the cell, it has different lysosomes that'll cleave that thioether linker, and so then the microtubule goes and basically wreaks havoc on the DNA. So pretty cool. And this is because it has the trastuzumab targeting and the microtubule combination. It does still allow for that selective delivery to those cells that are more highly expressing HER2. And then leads to cell cycle arrest and apoptosis, just like the others. So as far as indications for this one, HER2, again, metastatic breast cancer is the big population. So previously treated with trastuzumab or taxane, either together or separately, and then they also must have had prior therapy for their metastatic disease or a recurrence during or within 6 months after completing adjuvant therapy. So a couple of different qualifications. And I'm really sorry that you can't see this in action. Just rub it in a little more. I'll send out the link to the video because I know you guys all really want to see it. So dosing for this one is pretty straightforward. So 3.6 mg per kg every 21 days until disease progression or toxicity. That first infusion should go over 90 minutes, and then again, if it's tolerated well, subsequent infusions can be given over 30 minutes. And
this sounds like the video actually.
So you can use, it does require a filter with this one, and recommends that you monitor for an hour and a half after the first infusion and then a half hour after each subsequent infusion. As far as dose adjustments, there are no renal or hepatic dose adjustments recommended, but this does have a long list of kind of toxicities to monitor for and potentially dose reduce. So again, you'll see infusion reactions there. Also, any sort of hematologic toxicities. The big one that they called out here, and you'll see on the next slide, is thrombocytopenia. Cardiotoxicity is, again, monitoring that ejection fraction. The hepatotoxicity can manifest itself either as hyperbilirubinemia or AST or ALT elevations. peripheral neuropathy, and then again the interstitial lung disease with palm toxicities. So each of those calls out specifically kind of the severity, the grade of it, sometimes the number of occurrence it is, and then based on that, it'll recommend specific dose adjustments. So if you have a patient on this drug who experiences any of those, I would consult the package insert. So this is just going into a little bit more detail about the severe and more common toxicities. So again, this is one that specifically calls out checking the ejection fraction prior to beginning therapy and then every 3 months. So to me, I guess, Mary, to answer your question earlier, if trastuzumab is requiring it, it would probably make sense to do it every 3 months for just plain trastuzumab.
I agree.
They probably just were more stringent in the black box warning.
Mm-hmm.
For serious hepatotoxicity, again, I said that it could affect either your transaminases or the bili, so it recommends to check those before every dose because it may require pretty significant dose reductions. Pregnancy, another kind of recommending effective contraception. And then this is one that has a black box warning for sound-alike medication because it can be so easily confused with trastuzumab. And because the dosing is different, I think that potential for medication errors is so big that the FDA thought it warranted a black box warning. So hopefully something that we will never have to deal with. And then thrombocytopenia, like I mentioned on the previous slide, 83% of patients get some sort of thrombocytopenia, which is huge. And the nadir of this occurs around day 8 of therapy, so you can hopefully see those come back up after about a week. Other big things, like I said, I was shocked by how many people had transaminase elevations. That's like almost everybody. So definitely something to monitor for and make sure that they're getting the appropriate dose reductions. So I thought it would just be kind of interesting since they have very similar kind of indications to compare the costs of trastuzumab and trastuzumab. So this was my attempt to parse out the difference in dosing and all of that. So hopefully I did calculations correct. So for a 440 milligram vial, our cost is about almost $4,000 basically. So for a maintenance dose of 6 mg per kg every 3 weeks for about a 70 kilo person, if you rounded that to the nearest vial size, that would be about it. And then for the trastuzumab, I did my best to do calculations and found that would be about $7,200. So, Mary, you're frowning.
So for what period of time is that? Is that a single dose?
That's like a single dose, yeah.
Okay.
So why would you compare those?
Yeah.
I was just because they had similar indications, I wanted to kind of see how the drugs parsed out.
Have they been studied in the same setting? Or have they both been studied first line?
So, interesting. You asked, Jason. So I found this Teresa study.
The plant.
I do not.
So it was kind of an interesting study because it was for HER2 positive breast cancer, and they had to have had a HER2 directed therapy already in the advanced setting, which was either trastuzumab or lapatinib in previous taxane therapy. And so they compared it into 2-to-1 with trastuzumab, the entancine versus physician's choice. So that's the trastuzumab entancine. I should have used more similar language through it all. And so when I looked at the study, I was like, physician's choice, what does that mean? And then so this says that the physician's choice consisted of combination regimens with one or more HER2-directed agents in 83% of the patients that were in that physician's choice trial. So,
but this one would be used as a single agent, right? The
Right.
trastuzumab and tansine, whereas
Yeah.
the trastuzumab
It's
is
in
usually used in
combination.
combination.
I see what you're saying.
That's,
Okay.
yeah.
And this is in pre-treated patients.
Yes.
I think it was studied in I thought it was in metastatic, not pre-treated,
Right.
and there's no difference.
I think the year you were a resident, we had a doctor that did the original study speak at Hopewell.
Okay.
It's pretty cool to hear him.
Well, that's something I can definitely look further into. Breast cancer is by no means my area of expertise quite yet, so I can soon though when I have that rotation. But I just thought it was kind of interesting. They did find that the they had a significant amount of patients that crossed over to the 8-0 trastuzumab emtansine, and they did find that the progression-free survival was significantly improved, but they didn't find that difference in overall survival. So, but I just thought it was kind of interesting.
What was the landmark study that got approved?
That is
I don't know. I don't know the answer
It's
to
not
that.
a girl name. Well,
I actually
look it up.
I like all of them.
They're all girl names.
No.
I like it.
Not at all.
That makes sense.
It's Amelia.
Amelia? Okay. And so, because I'm hoping that you guys get CE credit for this, and I have an email out to Susan Luskin that I haven't heard back on yet, but I incorporated some questions throughout, so, to make sure that we get that to go through. So, which of the following is a black box warning associated with trastuzumab? By a show of hands, who says A, cardiomyopathy? And, beautiful job, guys.
You can't raise two
Two
hands.
hands.
You really killed it. I'm really proud of you guys. Alright. I figured I'd practice my Great Lakes skills too while I'm at it. Alright, so the next group of drugs.
One question.
Yeah.
How do you determine, how do you even find this? How do you know the cancer has routine?
I assume that you can test for the
Yeah, what's the test? What kind of test is it?
I'm not sure.
Yeah. So either IHC or FISH.
Oh,
And
okay.
There's been a lot of setup on what is IHC 2 scale of 2 good enough to get this drug, or IHC 3.
Okay. Oh, so reports
I was
like
wondering if there's any updates on that.
I didn't specifically look at that. I didn't know that was a controversy. So basically it like reports the kind of level of HER2 expression.
Yep.
On the
so
tumor.
for IHC it would, and then FISH is just plus or minus. So
Right.
It's very sensitive.
Yeah.
Much more so than IHC would be. And like initially insurance coverage depended on these scores, right?
I think they've
Oh,
now,
and
they
now they're
now
kinda-
allow it to at 2 rather than it used to have to be
Sure.
3. I
And
believe.
so it's a little more lax than it used to be.
Okay.
I think they've shown some evidence that it works in lower level of HER2 overexpression.
Liz knows though that we have that information was in the DHEP chapter too, so.
That's good to know. Alright, so EGFR now. So cetuximab or Erbitux is our first one here. So I didn't go through this at the beginning, but I tried to, in the first presentation that I did on monoclonal antibodies, it broke down how the nomenclature relates to the type of antibody it is. So this one being the XI-mab is the recombinant chimeric antibody. So this binds to the EGFR, to EGFR, and competitively inhibits the binding of the ligand as well as other ligands. And this process results in the phosphorylation and activation of the kinases associated with that receptor. So this then kind of kicks off the inhibition of cell growth, induction of apoptosis. It has like 5 different mechanisms of action, but I couldn't find a great video for this one. They were all like 10 minutes long. So they're pretty interesting though if you like graphics like I do. So, but I didn't torture you guys with this one. But then the EGFR signal transduction results in the RAS wild type activation. So if you have the mutant cell, then they are unaffected by this. So indications for this one are the KRAS. Again, you'll see the wild type. That's the one you want. The KRAS wild type, colorectal cancer that's metastatic, or squamous cell head and neck cancer. And then off-label indications were advanced colorectal cancer and a biweekly administration, as well as advanced non-small lung cancer that's EGFR expressing, or unresectable squamous cell cancer, skin cancer. So dosing with this one is 400 milligrams per meter squared over 20 minutes for your initial dose, and then subsequent doses are 250 per meter squared. So half the time, so over 60 minutes. Again, no recommendations. A lot of these didn't have specific renal or hepatic recommendations unless they were associated with like hepatic toxicity, but it does have recommendations for the different types of toxicity. And this is one that can cause a lot of skin toxicity and rash. And so if it's grade 3 or 4, it lays it out by, first, second, third, fourth occurrence. That'll determine whether or not you can just kind of drop doses, delay therapy, or discontinue completely. And so administration, they recommend an observation period of 1 hour after the first dose. And they also specifically recommend an H1 antagonist prior to the initial dose as a pre-medication. And then this is another one that needs a filter, and then I just put the maximum infusion rate. I don't think we would ever kind of get that, but. So the black box warnings for this are cardiopulmonary arrest, which, yikes. So in people.
We've seen it happen though, haven't we, Koth, in the chemo room?
Yeah, I was surprised. So they said people receiving concurrent radiation, 2% of people can experience
I
this.
think it's pretty high.
Yeah. And then with people receiving chemotherapy, that's 3%. That seemed high to me for such a severe adverse effect.
But generally when we have a code blue, except for the other day, it's cetuximab.
Not iron sucrose.
Not iron sucrose.
Yeah, that was. But because of this, they recommend really closely monitoring the electrolytes before and after the infusion. So this is one that if I ever see, I will make sure their electrolytes are within range. So especially the cardiac ones, so your calcium, magnesium, and potassium. And then infusion reactions too. They said there about 3% of people, or 3% of infusion reactions were serious, and then the fatal outcomes were rare, less than 1 in 1,000, but that's still something, obviously, that's probably too high for my comfort. And then some of the other adverse effects are listed below, so you'll see a lot of these again and again. Fatigue was very high, that the discoloration of the skin and acneiform eruption were very high on this one. And then neutropenia, almost half the patients had neutropenia, which I thought was pretty high. So our next one, and then I'll also go through a study that compared cetuximab to our next drug here, panitumumab, at the end. So I know you guys are in eager anticipation of talking about that clinical trial. So panitumumab is our next guy here. So this is a recombinant human IgG2 antibody. So it doesn't have that XI, it has the U. So that is usually a good sign, less infusion reactions. I don't want to spoil the story. But this, again, binds to the EGF receptor and competitively binds, blocking the ligands from binding. Again, kind of blocking that whole phosphorylase cascade and inhibits cell survival, growth, and proliferation. This is another one where you have to have the KRAS wild type. Dosing for this is 6 mg/kg every 14 days. And the dose adjustments are, again, for infusion reactions or dermatologic, ocular, or pulmonary toxicities this time. So FDA approvals for this guy, metastatic KRAS wild-type colorectal cancer. It's first line with FOLFOX, and then it says progressive disease after prior treatment with the 5-FU-oxalpa and irinotecan containing regimens can also be used as monotherapy. And then there was an off-label indication for instead of first line with FOLFOX to do with FOLFIRI. So just probably how it was studied. So administration, it has length of administration depending on the overall dose size. So if it's over a gram, it has to be administered over 90 versus 60 minutes. And then subsequent infusions, if they're tolerated well, can be given over a shorter period of time. And this is another one that specifically calls out the line should be flushed with normal saline before and after the infusion. So panitumumab, dermatologic toxicity. This is a pretty high incidence still. So it said it was seen in some degree in 90% of patients. There were 15% of patients that had a grade 3 or higher. So it has really detailed dose reduction guidance if the patients do experience this, because they did have patients who had these skin reactions that were complicated by infections, sepsis, there's the neck fash, abscesses. So even though, I think we sometimes forget about how much of a protectant our skin can be, so if that's compromised, it can really lead to some pretty bad things. Other side effects are listed below then. So overall, when looking at this versus cetuximab, it looks smaller. And then, so this is the ASPECT trial. So that compares cetuximab versus panitumumab. in patients with metastatic colorectal cancer. So basically 1,000 patients, which is a pretty decent sized clinical trial in oncology. So about half and half received the FDA approved doses. They found that the overall survival was 10.5 months for panitumumab versus 10 months for cetuximab. So panitumumab was found to be non-inferior to cetuximab. As far as skin toxicities, 13% of patients in the trial experienced this with panitumumab versus 10% with cetuximab, which was much lower than what they had reported in the black box warning kind of description, which made me feel a little better. So maybe they were just overly cautious about reporting that in the initial trials for FDA approval. And then the grade 3 for infusion reactions, as you can see, because of the type of monoclonal antibody they are, it was less with panitumumab, less than 0.5% versus 2% with cetuximab. So all of this combined, I think you can kind of see there are a couple of things that favor panitumumab or cetuximab, which is kind of why we favor that one. Also, patients have to come in less for it because it's every 14 days versus weekly. You don't have to do a loading dose with panitumumab. So I think the kind of decreased number of infusion reactions, all those are really good considerations. I think cost-wise, when I looked at it, it was pretty comparable actually, but when you think about the patients have to come in every week and nursing time and all the supplies for that.
We actually saved quite a bit of money
Did
by
we?
switching to this.
That's
Yeah.
good.
It was a resident project last year.
Junior J
And Kate,
and K.
Junior K.
Junior K. The combo.
Combo,
I like it.
dynamic duo.
But I think it's kind of cool. I think it's pretty rare that we see head-to-head trials like this in oncology.
This is actually
so.
really
Yeah, this was one of
good,
the
right?
yeah.
It was a single agent, right?
Mm.
Right.
Mm-hmm.
Yeah, I actually have the numbers if you guys are curious. So it looks like the projected, that was what Kate just projected, it was $56,636 plus 25 chair hours versus panitumumab's
Yeah.
49,000.
So I think the chair hours is
12
huge,
chair hours.
especially.
So like that.
Yeah. So next question here: what is not a reason that panitumumab may be preferred over cetuximab? And this is not how you should structure your Great Lakes question. I know.
Now you know.
No, I was good about that. Oh wait, I gave it away. Okay, by a show of hands, who says A, less frequent administrations? B, lower, not a
This is
reason.
why you're not
That's exactly why you can't do that.
B, lower incidence of infusion reactions. C, lower incidence of grade 3/4 skin toxicity. And D, potentially shorter infusion time. What's the answer, guys? Okay. That was the one thing. They did have less infusion reactions, but they did not have less grade 3/4 skin toxicity.
But it wasn't significant, was it?
No. It wasn't more though. Like that wasn't a reason that we made that would
Okay.
be preferred. They were
Although
comparable.
The GI docs do feel that it has
Thanks.
more
Anecdotally.
rash. Yeah. Dusty especially.
Okay.
They feel it has more?
Yes. Panitumumab.
Yeah. Which I mean is what the clinical trials have showed. So, all right. Bad job. Gotta cruise through these 20 minutes. All right. First one is the lovely bevacizumab. So this is a recombinant humanized. So you have the ZU for humanized. It binds to and neutralizes VEGF, which prevents it binding with the endothelial receptors. This in turn inhibits the angiogenesis and microvascular growth of the blood vessels. Just like that. Yep. Dosing is 5. There are a lot of different schedules and doses that are associated with bevacizumab, depending on the indication and what other drugs it's with. So I just made it really general here. So 5 to 15 every 2 to 3 weeks is a pretty common range. No dose adjustments for renal or hepatic impairment, and then if they have any sort of severe toxicities, I just recommend to stop the drug. So it has quite a few different FDA approvals that I've listed here. So you can see a pretty wide variety of types of cancer, so anywhere from cervical cancer to colorectal to glioblastomas, non-small cell lung cancer, renal cells, so a lot of different indications with other common therapies. And then it also has some off-label, so we actually have a non-onc in here, age-related macular degeneration, and then also some off-label things for with specific regimens for metastatic breast cancer, endometrial cancer, and soft tissue sarcomas. So this is one that should not be mixed with dextrose-containing solution, so another one where normal saline should be the preferred base solution. And then as far as administration time, it said to administer the initial dose over 90 minutes with subsequent over 60 and then 30 if it keeps being well tolerated. An interesting part about this one is that because of the way it interferes with angiogenesis, it says to hold for 28 days before and after any elective surgeries. So that's kind of a really good thing to keep in mind. So I don't know if physicians and nurses are always kind of looking out for that.
Well, we know it hasn't. We had a huge PSN.
Oh, did we?
Yeah, where Dan Mulcairn's patient was actually, the patient went to surgery and they didn't know it, and then the nurse gave the dose because he had already pre-signed the chemo.
Wow.
And the patient had like it was like a drain still coming out from the abdominal surgery. It was a bad thing. So it really is something that we need to keep an eye out for.
I didn't
think that people know
I didn't realize
this,
it
but they
was
don't.
that much time. Like 4 weeks is a significant amount of time.
Yeah, it really is, isn't it?
It makes
before
sense,
and after.
but
And the
before and
surgeons
after.
here are really worried about it. Like
Yeah.
on P&T, there's been lots of discussion about
Yeah.
how do they flag it, and that's one of the reasons now you'll see like the flag with the patients on an oncology treatment.
Oh.
So if they have a treatment plan applied and they come in for some sort of procedure or emergency procedure, the surgeons know how to look up what it is.
That's interesting.
Which I think is interesting too.
What % of surgeons you think know what to look for though?
Well, I'm not sure.
I'm just curious.
Hopefully they'd at least
Not a
ask the
lot,
question.
Yeah, I wouldn't-
They're supposed to know that.
Yeah.
Well, they should.
Yes.
I know there was a time in clinic too that a patient had just gotten a port, so for that first cycle they like held the bed.
The bed,
I don't know
yeah.
if that's
Yeah.
comes up a lot
That could
or
be
not,
part of
but-
patient education too, like
Yeah.
with warfarin is like,
That's probably
don't
true.
go to
We should do
surgery within
patient
4 weeks.
education
And
with
It
that.
really should be included
Yeah.
in patient education. I wonder if the nurses are doing that now.
Yeah, I don't know.
Kind of interesting.
Yeah. Alright, so now to the adverse effects. So it does have a couple of black box warnings associated with it. GI perforation is one, so it can occur in 0.3 to 3.2% of trial patients. And if this were to occur, it can be fatal, and they say to just permanently discontinue the drug. For the severe fatal hemorrhage, again, because it's interfering with the angiogenesis, it can manifest itself either in like hemoptysis or GI bleeds, central nervous system hemorrhages, vaginal bleeding. They've seen it kind of pretty much everywhere. So it says if the patients have had a serious hemorrhage or even recent hemoptysis, and it says any more than 2.5 milliliters, which is a pretty small amount, I think, to not give the drug at all. So avoid use completely. And then proteinuria. Oh, that's on my bullet. We'll get there in a second. Wound dehiscence. We already kind of talked about that. Holding it within that 28 days pre and post, because serious and fatal events have occurred previously. So some of the things we monitor in our treatment plans are about hypertension there and then proteinuria. So proteinuria, so it looked like the incidences were pretty decent actually. There were 4 to 36% total, but more than 2%. Let's see. Grades 3 and 4 were less than 7%, but the median onset 5.6 months was. So it's not necessarily going to occur when patients first start therapy, but when they're on it for months and months and months, it's something we should really kind of keep an eye on when they're months into therapy. And then median time to resolution was another 6 months. So kind of a time-consuming process, not something that'll go away. Alright, so this wasn't directly comparing bevacizumab. I included this more as like, this is what bevacizumab can be used with. And this was just recently published in the Lancet Oncology, I think in October of 2015, so a pretty recent trial. But this was looking at bevacizumab with either FOLFIRI or FOLFOXIRI in patients with unresectable metastatic colorectal cancer. So they used the bevacizumab 5 mg/kg dose with each cycle. And then you can see they broke it down. So I put the overall survival for the different regimens. So they did find that the FOLFOXIRI had a better overall survival. And then they also broke it down by subtypes for the different mutations. And I thought it was pretty interesting that patients with the BRAF mutant group had such a significant decrease in survival. So not all attributed to the Bev, obviously, but something interesting. Alright, ramucirumab. Gotta start cruising here. Alright, so this is another one that is a recombinant human antibody. You have that U. High affinity for the VEGF receptor 2. So that's, and it competitively binds and inhibits activation by preventing the other ligands from binding. So it's kind of similar to bevacizumab that it reduces tumor vascularization and growth. So dosing for this one is a little different based on the indications, as you can see there. And then it is FDA approved for a couple of different types of cancer, so colorectal cancer, metastatic gastric cancer, and non-small cell lung cancer. Sorry, I'm kind of cruising through because we have a lot more drugs to get through still. And so this has another one that they have no specific dose adjustments for renal, not really studied in severe hepatic impairment, but they didn't have any specific recommendations either. But it does have a lot of different recommendations for different types of toxicity. And these are ones that you'll see really similar to the bevacizumab, so things like infusion reactions, hypertension, proteinuria, any sort of bleeding, GI perforation. They also did mention this reversible posterior leukoencephalopathy syndrome, which sounds really terrifying to me. And then, again, wound healing complications. It said the disease is about. That one's pricing. This is another one they recommend specifically pre-medicated with an H1 antagonist if they've had a prior, even a low grade, like grade 1 or 2 infusion reaction. Infuse it over an hour through a filter prior to any chemotherapy and flush with normal saline. So the black box warnings for this are pretty similar to bevacizumab, the hemorrhaging. They had both general hemorrhaging in their recommendation or in their warning, and also specific to GI. So GI bleeds can be really severe. The GI perf, again, potentially fatal, so discontinue the drug if patients were to experience that. And then with the wound healing impairment, they didn't have a specific recommendation like they did with bevacizumab about the number of days to hold before and after. But it did recommend 2 holds, so I would think that would probably be pretty similar in time. And then this one, I put the adverse reactions there. The percentages actually look pretty small to me compared to a lot of the other monoclonal antibodies. Maybe it's just that it's not used as widely, and so we just don't have enough picture yet. All right, now to the T cells. So we'll try to whip through these pretty quickly. First one is Jenny's favorite, I think, right? Ipilimumab. It's up there. It's up there. So this is a recombinant human IgG1 monoclonal antibody that binds to that CTLA4, the antigen, which is a downregulator of the T cell activation pathway. So basically, you're kind of like taking your foot off the brake and helping your T cells to fight the cancer. And so this is FDA approved for metastatic or resectable melanoma. Also adjuvant treatment of cutaneous melanoma if they've had renal lymph node involvement that's large and after resection. And then when I first made this slide, this was an off-label indication, but just recently FDA approved. All right. See the excitement in everybody's face. Who's pumped? All right. So with nivolumab, very exciting. Why are all these happening twice, Lauren?
I did not touch that.
They did have for adjuvant treatment, the dose was 10 mg per kg every 3 weeks for 4 doses. Then take 10 mg per kg every 12 weeks for up to 3 years. And then if it's for unresectable resectable or metastatic melanoma, which I think is what I've seen most commonly, is 4 mg per kg every 21 days for 4 doses. And then that first and last dose must be administered within 16 weeks, which is something it's kind of unusual, I think, too. It makes sense kind of for how the drug works, but not something we usually are keeping track of. So dose adjustments are here for elevated AST or T-belly. An interesting part of this is for the recommendations for kind of minor elevations, it says to temporarily hold the drug, but if it's severe, it could be kind of an immune-mediated reaction, and so they actually recommend to start prednisone. And I'll get into that a little bit more too as we go further into this drug. So other dose adjustments for all of those different organ systems, and so the immune-mediated toxicity can really involve any organ, which is I think why I have those all listed. The doses should be administered over 90 minutes, again with an inline filter, and can be flushed with either solution. So the big black box warning about these immune-mediated adverse reactions, again, these can occur in any organ system. I think the one that I most commonly hear about is the GI area. That's probably the most common, but they have had reports in all of these different areas. So they generally occur during treatment, but have been reported for weeks to months after treatment has been stopped. So just because you stop the drug doesn't mean you're in the clear. And after I get through, I'll go kind of through management of these a little later in the presentation. So other adverse effects are listed there, but I think the big thing that we watch out for is those immune-mediated reactions. Alright, so this slide goes to specific management. This is again courtesy of my awesome co-residents.
I even did it by the GI side effects.
I like that, perfect. So it usually can manifest itself in a wide variety of ways. So diarrhea, abdominal pain, mucus, blood in the stool. Patients can be febrile or afebrile. I'm not sure why I put that parentheses in there. So the first recommendation they have is, especially if it's mild, to rule out any sort of infectious etiologies like C. diff, other kind of things like that, and to consider the endoscopic evaluation. You can use antidiarrheal treatments. Was no question I had for you, Jenny, when we had a patient come in with this. I wasn't sure if that was something that would be okay, but they do say that that's okay for symptom management. For moderate reactions, it recommends to hold ipilimumab. If symptoms persist more than 7 days, to start low-dose prednisone at 0.5 mg per kg per day or equivalent. And then if it's a severe kind of reaction, obviously permanently discontinue the drug, and it recommends starting a higher dose prednisone, so 1 to 2 mg per kg per day. When I've seen patients come in with this, they haven't really said this looks moderate or severe, but this could potentially get worse, so I kind of uniformly see them started at 1 mg per kg per day of the IV methylpred, so kind of more of a practical spin on it. Steroid taper should begin when improvement to grade 1 is seen, and the taper should occur over at least 1 month. And then I know another question that came up, we had a guy who had really serious colitis that wasn't responding to steroids right away, and so they had started talking about adding infliximab, so that anti-TNF or other immunosuppressants. So there are some case reports out there about that, and that is specifically a recommendation if they're not responding to those high-dose steroids. Alright, pembrolizumab. So this is a humanized antibody that actually targets, it's an anti-PD-1, so it binds to the PD-1 receptor and inhibits the binding of the PD-1 ligands. So this inhibits the negative immune regulation and programs cell death. So basically, again, you're reversing that T cell suppression so that your immune system can be more active against the tumor. Indications for this are in, again, melanoma, and then also in non-small cell lung cancer for patients who have those, for that PD-L1 expressing tumors. So that is something that they'll test for. Dosing for that is 2 mg per kg every 21 days. This is, again, infused over a half hour with a filter. No dose adjustments recommended for renal dysfunction. They do specify whether or not if your patients have hepatic impairment, if it was pre-existing, they don't have specific recommendations, but if patients develop hepatic impairment while on the drug, then they do have recommendations for dose reductions. So kind of something good to know whether or not the patients had it before or if because it is caused by the drug. These are a couple of other different toxicities that they recommend adjusting or holding the doses for, and again, they'll have specific recommendations based on the severity and occurrence. And these are some of the adverse effects. This is our first monoclonal. It doesn't have any black box warnings. Woo! So let's side effects though. So, some of the big ones here were that I noticed I pulled out were like hyperglycemia is something that I don't always typically think of with monoclonal antibodies, but something to keep an eye out for. Also affecting sodium and triglycerides. Nivolumab, which is one of the coolest new drugs, I think. So this is a human IgG4 antibody, another one that selectively inhibits PD-1. And this is, again, regulating that T-cell activation and proliferation. And it does say that when you combine this drug with IBI, it results in a T-cell function that's enhanced greater than either drug alone. So there is some benefit to using both together. FDA-approved indications are, for melanoma, also for non-small cell lung cancer, and for clear cell renal cancer. Dosing for this is typically 3 mg per kg every 14 days, unless it's used with nivolumab, then use a reduced dose, so 1 mg per kg every 21 days for the 4 doses, so kind of alongside the IBI. Dose adjustments, this is another one, it kind of separates whether or not patients had organ dysfunction prior to therapy or if it developed on therapy, so that's a good thing to keep track of. And then kind of the same thing for hepatic therapy. It hasn't been studied with severe impairment if patients are kind of baseline, have bad livers. But if it does develop during treatment, you can see recommendations about whether or not to hold, whether or not to permanently discontinue based on, and then based on the severity of the elevations, and then also if it's believed to be an immune-mediated hepatitis, to again start prednisone much like you would for ipilimumab. And there are a bunch of other, I had to look up what hypophysitis was, which is an inflammation of the pituitary gland. Just wanted to let you guys all know that. But these all also have dose recommendations for adjustments.
You actually saw that. Okay. That was bad. Yeah.
Hypophysitis?
Yep.
Yeah.
Really?
Yeah.
Oop.
I had to look it up at the time too.
Yeah, not a word that I hear very frequently, but good to know. So this is infused over an hour through a filter, and this is one that if you're administering with ipilimumab, to give the nivolumab first, so specifically calls out that order. This is another one that doesn't have any black box warnings yet, I'm sure, but it does have a variety of different adverse effects. I would think that risk for colitis and other sort of immune-mediated reactions is still there. It probably would respond to prednisone in much the same way, even though it doesn't have the black box warning yet. But it looks like it hits the electrolytes quite a bit, and then some, obviously, the liver and serum creatinine were both affected to some extent. And then I have one kind of miscellaneous monoclonal antibody here that I know Lauren had a big role in adding to our drug formulary. This is dinutuximab. So it's a chimeric antibody that binds to this disangliate. Do you want to? Yeah, GD2.
Cialo.
But it's highly expressed in neuroblastoma, most melanomas and other tumors, but it also is present on normal tissue, which when you get to the administration will make more sense. So things like neurons, skin melanocytes, and peripheral sensory nerve fibers. So it uses the antibody-dependent cell-mediated cytotoxicity and complement-dependent cytotoxicity to induce cell lysis. It's FDA approved for high-risk neuroblastomas, mostly your pediatric patients. Dosing here, it gets pretty complicated. The dose itself is the same, but depending on the cycle and the length of the cycle, it varies a little bit. So kind of complex. And so no specific recommendations for renal or hepatic dysfunction, but it has a long list of other toxicities that you would dose adjust for. Or potentially not even use if they already have some baseline. So this is the complex administration, and Laura, let me know if I miss anything, because there's kind of a lot. So it has, I put the rate there, and you can gradually increase the rate to a maximum of 1.7 mg per meter squared, but it looks like it's given generally over 10 to 20 hours each day. The big thing here is that they have to be on this morphine PCA. It has to be started prior to the infusion, and then during the infusion, and for 2 hours after, because patients just have like terrible pain with this drug. It also has to be given with antihistamine and Tylenol, and they said that if patients are having pain and fevers through all of that, you can also consider adding ibuprofen. And then normal saline bolus has to be given an hour prior to, over 1 hour prior to each infusion.
This will probably be on the ECOP exam when I was writing questions last year for this year, is like starting in the spring.
Oh, really?
I'm pretty sure that the PEDS questions will include one or so of this. I did not write any of the questions.
I'll send you my review article on it.
I like it.
The ones that's written.
So they have had some serious and life-threatening infusion reactions reported. So there's a black box warning around this, and it said that the serious reactions actually occur in about a quarter of patients. So it's not like just a handful; it's a pretty high number of patients. And so they recommend monitoring for infusion reactions during and for at least 4 hours after each infusion. The pain with the morphine PCA, they said is really seen in almost all patients. So that's why it is so important to get that PCA going. In clinical trials, they found that grade 3 peripheral sensory neuropathy occurred in 2 to 9% of patients, so that's grade 3. And then severe motor neuropathy was also observed when it was studied in adults, and that didn't always resolve. So that's kind of terrifying to me. And then there are a plethora of other adverse reactions that I listed here. So you can see pain, 85%, hypotension, and capillary leak syndrome, which is not a walk in the park by any means, 40% and 60%. Elevated ALT in over half patients, really severe kind of hematologic toxicities. So not an easy drug to take. And then for our last question, really quick, what option is not considered for the management of colitis secondary to ipilimumab therapy? Who says A, antidiarrheals, B, corticosteroids, C, infliximab, and D, simethicone for the gas? Okay. Well, thank you guys for coming and putting up with my technical dysfunctions. And please, any feedback would be
Don't we have questions?
welcome. Oh, and if you have questions, yes.
Okay, I got a quick question
I
for
went
you.
over time, sorry.
For the HER2 drugs,
Yeah.
what is the mechanism of the cardiac toxicity?
I don't know. I don't know.